Wow, technology is working. Good afternoon. It's great to see everybody. I'm Dr. Randy Fink, live from Colorado Springs, and it is time for Fertility with Fink and Friends. That is the only place that we all are on Tuesday afternoons at 4 p.m. in the mountains and 6 p.m. on the East Coast. It is great to see everybody here. 3 o'clock, let's see, 6, 4 o'clock, yeah, 3 o'clock on the West Coast. And it's been quite a week. I certainly hope that everybody had a wonderful holiday weekend. You got to do a little grilling, perhaps a little enjoying time with family and friends. The only downside to the holiday weekend is that it ends and then you have to come back to work, which is it seems to always add a kind of insult to injury. Looks like everybody is joining here. A special hello, of course, to Mrs. Vince in Kentucky. Always one of the first to join. My lovely mother in Mobile, Alabama is here. And I hope my father is not too far from you at this moment, because otherwise I think he's probably causing trouble. I'm just suggesting. Who do we have over here? Well, so we've got my Instagram side right here. Barbara Brown was the first to join. Hello, Barbara. Nice to see you today. And over here on Dr. Sasha has joined, and I am indeed very honored to have you here, ma'am. I enjoy all of your posts as well. So, gosh, all of our friends here, Miss Salustio 2021, happy Tuesday. Yes, indeed. Let's see. I see Bethany Flynn. I see Mrs. Brower from Idaho. Jenna is here. We've got just all kinds of people here. So how's it going? What you been up to? I like to call this Fertility with Fink and Friends. I am Fink, you are friends. I actually was... I tried to. Oh, now I forgot what I was going to say. When I was typing that in, my autocorrect made it something that was really ridiculous. And now, because I'm live here, I can't remember what it was. But in any event, we are back here in Colorado Springs. Let's see, it's 79 degrees outside. I know it's still plenty hot in most of the rest of the country. And of course, our thoughts are all going out to our friends in Florida who have dealt with the major storm, our friends in Hawaii who are still trying to recover from their fire, and all the fires that burn within each one of us. What kind of fires are those? Those are fires that tell us that we want family. Those are fires that tell us we want to be healthy. And those are fires that tell us we want out of life what we want out of life. If you noticed, if you happen to look at my Instagram, you'd see that earlier in the week, I drove past some deer in my neighborhood. There's always a lot of deer outside here. So when I lived in South Florida, we had crocodiles in my backyard. Now we have deer and bobcats, and sometimes some bears and some foxes and kind of crazy animals. But I drove past some deer, and it made me realize how happy, I was just to kind of see them there. It made me realize that we often overlook those little things in life that make us happy. And it's so easy to find reasons to be unhappy. Believe me, I am the professor of unhappiness. And it's just so easy to get caught up, to not see the forest for the trees, and to lose sight of all those little things that are out there that still have the potential to make us really happy. And I think as many of us go through this fertility process, that's a big leap to take, because there seems to be so much that's always working against us to keep us happy, to keep us from reaching our goals. That I thought it would be nice to just stop and smell the flowers, as it were. Little hummingbirds, deer in the yard, a joke told from a well-meaning doctor, a smile from someone behind the counter, somebody walking past you in the aisle at the grocery and just nodding to you and saying hello and smiling at you for no other reason than that you're there and that you're there together. So let's see if we can't all try to find reasons to be happier and to bring happiness to one another. So that's my lesson for the day. Let's see what we can do here to try to answer some questions. We've got Facebook and YouTube. Hi, Tamara is with us, and Jillian. Nice to see you both. Tamara says, what, and by the way, I saw a question over here. It looks like somebody may have answered it for me. Yes, all you have to do is type in a question here. That's to Mrs. Brower, and we are going to try to get to everybody's questions today. I can't always get to all of them, but we'll certainly do our best. I'm glad everybody's here. Tamara says, or is it Tamara? Please forgive me if I mispronounced your name. What are your thoughts about doing a fresh donor transfer rather than a donor FET? Is it possible to do a fresh transfer on day 5 and for the rest of the embryos to do PGT? So the answer to that is yes. Everything is possible, my friend. Everything is possible. So when you've got an embryo that is created from a donor egg, if we're going to do a fresh transfer with that embryo, then what we need to do is we need to get your cycle synced up in order to be able to retrieve the egg from the donor, to create an embryo and to grow it from 3 to 5 days, and then to place it in you so that your uterus, that your uterine lining is timing that implantation correctly. And so that's usually done by using birth control in the cycle before to get you where we need to be so that you're synced up with the donor. The advantage of a fresh cycle is that if, for instance, you have purchased 6 donor eggs, if you've purchased 6 donor eggs, then you're going to get all 6 eggs. Because they will all be fresh eggs and you're getting them. Now, they may not all fertilize, but you're going to get them. If you are doing a frozen transfer, then if you're purchasing frozen donor eggs, then when they go to thaw them, they may not all survive the thaw in order to be fertilized. If we are fertilizing those embryos fresh and then freezing them, well, the survival rate from a freeze there and a thaw is really above about 97%. So we can really expect that you'll get the same kind of outcomes. With if you're doing your own cycle and you're thinking about a fresh versus a frozen transfer, sometimes the body has really, as I like to say, has been in egg-making mode. And if you're really in egg-making mode, then you may not be as good as getting pregnant and keeping pregnant mode might be. So sometimes a frozen transfer is going to have a little higher success rate than a fresh transfer. Again, not to say that folks don't get pregnant from a fresh transfer every single day of the week, because that certainly does happen that way. But there is not a big difference in doing a fresh donor transfer versus a donor FET transfer tomorrow. So you can definitely pick one and do a fresh transfer on day 5 and PGT test the rest if you prefer. I think what makes more sense, perhaps, is to do a day 3 transfer with that fresh embryo and then grow the rest to blast and then PGT test the remaining. Because the advantage of doing the fresh transfer is that 100% you're going to be getting an embryo that goes inside of you, where it may have a chance to grow. Whereas if it's going in the lab, it may not grow in the laboratory. So I think it's better to maybe do a day 3 fresh transfer and to PGT the remaining, because if you're growing everything out to blast and then you're going to PGT all except for one, you might be kind of spinning your wheels there, because if you just wait 10 to 14 more days, you're going to know if that embryo was chromosomally normal. And so it just seems like better bet might be with a day 3 embryo, and hopefully that helps. Jillian asks, I've done 2 rounds of IVF, 5 transfers, 2 did not implant, and 3 miscarried, waiting on results from an ERA, and then we'll do a frozen transfer. So what protocol do you recommend? Well, if you're doing an ERA, an endometrial receptivity assay, and there's not a lot of use for the ERA anymore, but that may be one scenario because you've done 5 transfers. Now, 3 of them did implant, even though they ended up in miscarriage. That sounds like more of an embryo issue than a timing of implantation issue. But if you're doing an ERA, that is generally predicated on a medicated cycle. So, what cycle, what transfer protocol would I recommend? Generally, it's going to be a medicated protocol. Now, I do think that there is a little higher success rate with a natural cycle, and so I always stand by the natural cycle. But if you get some alternative number other than what we call receptive or 120 hours with that ERA test, then that's the one you want to use with a medicated cycle, because if we have the number, we might as well use it. The ERA is an interesting thing, and let's just talk about that briefly, because a lot of folks ask me the question, should I be doing an ERA? People still talk about it a lot on the internet and on social media. An ERA is an endometrial receptivity assay. And what that is that it gives the idea, it's predicated on this idea that there's a narrow window that we have as humans in order to be able to implant our pregnancies. And that most of us fall into that window. 75% of people fall into that window. But that means that 25% of people are outside that window. How do we know if you're outside that window? Well, the only way we can know is to test for it. And that's what an ERA is. Sounds like a great idea, right? Well, not so much, because they have studied this. First of all, they studied it. Should we be testing everybody with an ERA before we think about doing any transfers at all? And there are a lot of practices that would do that. Why? Well, they can charge for it, but the evidence shows that no, it doesn't help the general population. Well, in fact, the evidence now shows, looking at ERAs, the window is not as narrow as we thought it was. And whether you fall on one side or the other of the window, that it really doesn't positively affect the rate of live birth moving down the line. So we do not generally recommend an ERA, except for the situation where we've looked at everything else and can't figure out what the problem might be. So let's see what else we have here on the CNY Instagram side. Oh gosh, all my friends here. So Mrs. Brower asks, I was recently told by my local OBGYN that my eggs are no good or bad quality. That's not a nice thing to say about somebody's eggs. That's just rude. But in any event, bad quality because my day 21 progesterone is always at 0.2, and we have been considering IUI. Well, Mrs. Brower, let me tell you something, Missy, or Mrs., as we'll go with Mrs. So that progesterone level doesn't tell you a damn thing about whether your eggs are good or bad or anything at all about the quality. All right, so I think you might have been a little misinformed about that. The day 21 progesterone check is going to tell us, did you ovulate on about day 14, or did you ovulate during that cycle? The fact that yours was at 0.2 tells me only that you didn't ovulate. It doesn't tell me anything at all about your egg quality. And that's one more reason to maybe think about talking to a specialist so that you can get the right information the first time. And no disrespect to any doctor out there, but that is not what a progesterone level tells us. That just says that you didn't ovulate. Nothing at all about egg quality. What else we got going on here, people? Hello from Los Angeles to my friend Andre and to my friend Felicia, the realtor. Oh, yes. Hi, Eileen. Thank you very much for your text today. And you need more dad jokes. Well, gosh, you know what? You caught me off guard with that. I should have had something prepared. I really should have. Let's see. BJ Pumping says the effect of IVF with a frozen pelvis. So a frozen pelvis means that you have a lot of scar tissue on the inside. That scar tissue can sometimes have an effect on how things move around. So if we're going to do a surgery, like maybe put a laparoscope inside, we find an awful lot of scar tissue, and that can lead to issues with pain and so forth. But as far as from an IVF standpoint, shouldn't affect things really too much there, BJ. And hi to my friend Nikki Jones Fit. Hello. I hope you don't mind. I'm going to tell a little story about Nikki Jones, who was here a couple of weeks ago for maybe it wasn't a couple of weeks, maybe it was last week for a retrieval. And we had a great phone call, and I just want to share how good that was, because Nikki we got some eggs and went to make some embryos, and then Nikki got some information to say that she had no embryos, that none of the embryos survived. And I think the person who gave that information was either looked incorrectly or was just mistaken, because that was the news that Nikki got. And of course, it caused some heartbreak and tears. And I looked in the chart and found that that was not the case at all, that Nikki actually had some embryos that were able to be tested. They got sent off for PGT testing. And so that was the best news all day I could get. We talked about some of those little things in life that can make all the difference. Nikki, that made my day to be able to give you that information. And so now we just keep our fingers crossed for that PGT results to come back. And thank you for letting me be your favorite doctor. I appreciate that. Oh, Deerite one, how much CoQ10 do you recommend for egg quality, and how does metformin and LDN help with egg quality? And that's a very good question. So let me tell you, CoQ10 should be taken in what is known as the ubiquinol form. The ubiquinol, or sometimes called ubiquinone form. And taken in the ubiquinone form, it should be 400 milligrams a day. Why the ubiquinone form? Because it is the easiest for your body to digest and to process. If it's not the ubiquinone form, all is not lost. That's not a problem. It just means that you use 600 a day instead. I do think that that CoQ10 is probably, arguably, the most important of the supplements to take when talking about fertility. And that's whether you're doing IVF, whether you're going to do an IUI, or even when you're just trying at home. CoQ10 provides a source of energy in the cells that our cells need to divide and to be healthy. So like I say, I think that's one of the most important things. And I'm going to mention, before I get to the rest of your question there, do you know the one supplement I think that is most commonly forgotten or potentially misused? Any idea? Unless you're reading my mind, you're not going to know, or unless you've talked to me about this before. And that is something that's called L-arginine. L-arginine, the dose of which I am blanking on at the moment. L-arginine is in a lot of pregnancy and fertility supplements. However, the evidence shows us that L-arginine can actually be harmful to egg quality. For instance, I used to very routinely recommend a particular supplement that was used to increase the body's own growth hormone levels. And growth hormone is what keeps us young. So anything we can do to increase our growth hormone levels is going to have a positive effect on the eggs and on the ovaries. Well, so this supplement that will go nameless, until about a year ago, when I realized that it's loaded with L-arginine. And L-arginine, as I said, may have certainly some effect on increasing your growth hormone, but has been shown in really good quality studies to decrease egg quality. L-arginine is an important supplement for embryo transfer, and it comes from the book. It starts with the egg. It should be something that you're on if you're thinking about doing an embryo transfer. Embryo transfer support supplements are your prenatal, some CoQ10, some fish oil, vitamin D, vitamin E, and L-arginine. But L-arginine should not be used in stimulation because it has been shown to decrease egg quality. So please remember that. So that's probably the most misunderstood of the supplements. And the other thing that's probably one of the, I would say, well, okay, if you ask me what supplement is the one that is most easily overlooked, but that people would actually really like to take, that's a complicated question, but really the answer there is melatonin. there are higher melatonin levels in people with good quality eggs within those eggs. So when they study it, it takes a very, very tiny microscope to determine how much melatonin is in an egg. I'm telling you, I have such a microscope. So melatonin levels are higher in the eggs of good quality. So melatonin, usually 3 milligrams is the recommended dose, is an important thing to use when stimming and leading up to a stim, because that can improve egg quality. So, D-Wright, you asked me, how does metformin and LDN help with egg quality? So LDN, or low-dose naltrexone, is a routine part of really all of our autoimmune protocols. And so what we're doing with LDN is very, very broadly used in the anti-aging community, and I stand behind it with that. I took it myself for a while. For the people who take it, and if you look up low-dose naltrexone and anti-aging, people will say they never get a cold. They never get the flu. It really has a very strong protective effect against catching, things like these sort of viral illnesses. So what does it do? It increases our endorphin levels. Endorphins are things, I'm sure you know, the runner's high. Endorphin levels, if you've ever known someone who's had a baby, or if you've had a baby, you're going through just really utter torture to push that baby out. Baby comes out and suddenly everything is just calm and you can't stop looking at the baby. Well, actually, so when I deliver a baby, I catch the baby and then I just want to hold it. And I don't want to stop looking at the baby either. That's because my endorphins are high. And eventually somebody says to me, Dr. Fink, do you mind if we hold our own baby? Okay, fine. All right, so baby goes back. That's endorphins. That's making you feel that way, that amazement and that calmness that comes over. Endorphins happen after an orgasm. Well, that's something that, that's a good thing, generally speaking. LDN increases your endorphin levels, and anything that increases endorphin levels ultimately helps in the way we metabolize and in the way our cells function in terms of processing energy. So that's how it helps there. And it also decreases inflammation. Inflammation is another problem that can contribute to fertility issues and really is the fundamental basis for all illness in general. Metformin helps in a different way. So I used to be not a fan of metformin for a variety of reasons, but now I feel very strongly about it. If you at all have issues with a decreased ovarian reserve or with a diminished egg quality, I strongly recommend the use of metformin. Why is that? Well, metformin is a medication that we use to treat folks who have diabetes. It decreases blood sugar. Okay, well, that's a good thing. Also, interestingly enough, in the anti-aging community, metformin is considered to be a life hack, that there are many people who will take one a day just on an ongoing basis because of what it does to insulin resistance, which is the reason most of us have these guts here. And see, I'm wearing black today because it's so slimming. And you'd say, that's what you think. You haven't seen me from the side. Not so slimming at all. You see, and that just completely derailed my train of thought. Metformin, so insulin resistance. In the polycystic ovarian set, we'll often use metformin in order to help people to resume normal ovulation. But in IVF terms, metformin helps with egg quality. It has something to do with that treating insulin resistance, but I'm not sure that the precise mechanism is well understood. However, hopefully that's some helpful information there. D-Wright, glad that you could be with us today. Shay is over here on the Facebook side and says, are all PCOS eggs poor? No, absolutely not. But what happens for folks who have polycystic ovaries is that you tend to respond really well to medications. to the medications that we use to stimulate your ovaries. And so we give you these meds, you make a huge boatload of eggs to produce. Well, a large proportion of those eggs may not be usable, but still a large proportion of those eggs may be. So what that's articulating is that quantity is not the same as quality. So I personally, and there's some differing opinions on this, but my opinion, I'd rather give you a little less medication because I'd rather focus on the quality of those eggs rather than the quantity. Because if you make 60 eggs, what are you going to do with 40 embryos? I mean, it's a great problem to have, but you probably are going to have some component of those eggs that aren't going to be good, that won't fertilize, or that will make embryos that are unhealthy because of that very, very high estrogenic environment in which they're created. But that too is a really good question there, Shay. And I'm sorry, Julie, I missed you. Oh gosh, I missed a couple of them here on the Facebook side. So forgive me. I'm going to try to work my way up there. Julie, hi from Pullman, Washington. Hello. Consult scheduled for November. Talk to me about carnivore keto. It seems like the diet's used for weight loss, but you have been, because you have a BMI of 18, you were advised by a prior practitioner to put on some weight to increase fertility. So I grudgingly put on 15 pounds. I don't want to lose what I work to gain. So is carnivore keto a good idea for those of us who are trying not to drop weight? Hey, Julie, that's a really good question. So, Dr. Kiltz does a lot of his work on keto carnivore. And the answer to that question is that it really goes back to inflammation. What is inflammation? Inflammation is where a byproduct of our metabolism, which is called a free radical. So a free radical, what is a free radical? It's a floating little kind of electron, a little piece of electricity, a little charged particle that floats around in our system. Where does that particle come from? Well, let's say we have a molecule of, I don't know, let's say we eat a steak, all right? That's protein. We break down that, we metabolize that steak into its component parts. Well, as it's breaking down, the breakdown process is not completely even, and so it leaves behind some little free floating pieces. Those are those little charged particles that are called free radicals. Free radicals float around our body, and they end up attaching to our cell membranes in all different places in our body. And when that happens, they cause injury to those cell membranes. That is what is called inflammation. Inflammation is the basis of really every disease. It's the basis of heart disease, of blood pressure disease, of cancer, of autoimmune diseases. Inflammation is the constant uphill battle that our bodies face. You can see inflammation when you fall and you skin your elbow and it gets all red, and the redness is inflammation. That's an immune response. The little weeping stuff that kind of comes out of the wound. Sometimes you get a little infection. Pus is some dead white blood cells that happen there. That's all part of the inflammatory process that our immune system mediates. Well, the keto or carnivore diet is said to decrease inflammation. Keto is high fat, moderate protein, and low carb. High fat, moderate protein, and low carb. So the carb part we know is pro-inflammatory, and you know that because if all you eat is bread and pizza and pasta, you're probably going to be putting on weight, and you're going to have issues with, in terms of inflammation in your body. So Dr. Kiltz is a great one to talk with about that. Whether you believe in keto or carnivore, the thing that we can all agree on, and really most diets, be it the Mediterranean diet, be it Weight Watchers, be it whatever these things are that are related to weight loss, the one thing they have in common is low carb. So the high fat is anti-inflammatory, and you may know this because if you've done treatment with us, many of you have used an intravenous process that's called intralipid. Intralipid, it looks like getting a milkshake, but you get an IV. It's a fat infusion. It's basically the IV version of the keto diet. Why do we do that? Because it is basically it's a very potent natural anti-inflammatory. So yeah, Julie, I agree. I don't necessarily want you to be losing weight. The reason they probably told you to gain some weight is because we process our hormones, our steroid hormones, things like estrogen and progesterone, in our extra fat cells. And so for women who are low on body fat, you may stop having periods entirely because you don't have enough body fat to be able to process that estrogen. And so it just makes your body a little more responsive to the normal hormones, to ovulation, and to fertility if there's enough fat there to be able to process. So, Julie, I think that's probably what was going on there. Missy Melissa, my 22-year-old daughter will be doing an egg freezing very soon with your practice. She lost her left ovary tube in July due to endometriosis. Her right ovary is now half the size due to an endometrioma. How long can frozen eggs last? I hope that the therapy doesn't mess with the right ovary too much. Well, so the first thing in that situation, Missy Melissa, is that I would certainly recommend don't do more surgery on that other ovary, because when we go to remove endometriosis from an ovary, that can have an adverse effect on AMH, on ovarian reserve. AMH is the anti-Mullerian hormone. So usually what we can do when we're doing an egg retrieval is that we can just kind of skirt by the endometriosis and get the residual eggs that are in the rest of the ovary. So I don't want you to lose too much sleep over that. All is definitely not lost in your daughter's situation. How long can eggs last? In theory, they can last forever. So we get them, we freeze them, and they should stay good here until she's ready to use them, with the understanding that she may not need to use them at all. So the thing that I tell folks about egg freezing is that it's like purchasing a fertility insurance policy. You can absolutely 100% still get pregnant in the normal way. But if there's a problem, if you need these eggs later on, you're having difficulty getting pregnant, well, the earlier we get these eggs from you, and in your daughter's case, she's 22 years old, so these are going to be young, healthy eggs that will be here for her, really forever, until such a time as she might want them or need them, even though she may not at all. So best of luck in that endeavor there, my friend. Let's see. Oh, hi to Fairy Tale 404. Nice to see you there. And Gabby Thorpe. Hi, Gabby. HCG is 133 today, but progesterone was 10.8. Should I prepare for a miscarriage? God, I certainly hope not. So let's talk about those numbers. That HCG level, that's a good old positive blood test. That is certainly more positive than anything I would expect from residual HCG in the body or having done HCG boosters. That is a big plus. So bing, good deal. That progesterone level is not bad at all. Many practices will use the number 8 or 10 as their level of expected progesterone after an FET. At CNY, we use the number 20 because we built in an extra margin of safety there, Gabby. So, yep, not surprising. They increased your PIO, your progesterone in oil, just to give you a little bit more. But nope, that is not what if that number came back at 2, then I would say, that may be the sign of an unhealthy pregnancy. But at 10, that's a good number. So congratulations. Oh, that makes me so happy. And it is all about my happiness. Let's just make sure that we are all completely clear on that. All right. What else we got going on here? Oh, yep. Hi from North Dakota to my friend Felicia. Shanna is asking, do I advise HCG boosters after an FET? FET is a frozen embryo transfer. I do think the HCG boosters are important if you have done a natural cycle FET. So the HCG is, of course, the pregnancy hormone. And when we use a booster, that means we're giving you a little bit of extra HCG hormone that happens sometimes right after the transfer, sometimes right after trigger, sometimes after transfer, sometimes after positive pregnancy test. I usually like to do it after transfer in a natural cycle. It becomes progesterone in your body. That progesterone is the hormone that you need in order for the pregnancy to grow. So get a little bit more progesterone by doing that. Now, in a medicated cycle, we are giving you so much progesterone that the HCG boosters really don't do anything. They may make you feel like you're doing something because you're giving yourself an extra shot every day, but they are not, strictly speaking, necessary. If you've done a natural cycle, please use the HCG booster. Hi to Paige. Away goes Paige, and here comes Paige. Glad to have you here. Hello, Zaneta in Miami. Nice to see you. Okay, so loyalty over royalty. I like that. Thank you. Oh, thank you. My pleasure. Thank you for holding my hand before I went to sleep during anesthesia. It was an unforgettable and memorable moment. Well, it's my pleasure. Thank you so much for being here and letting us really be a part of your life. Let's see what we got on the CNY side. Mrs. Bauer went back to say, we would be told we'd be wasting our money on an IUI. I can't use Clomid or Letrozole. I've had cysts in the past. People, the using an IUI, so some people will get pregnant by doing an IUI, and when that happens, that's fantastic that it happens. But the truth is that the pregnancy rate from doing IVF is so much higher. So with an IUI, we may be able to give you anywhere from perhaps a 5 to a 9% chance of pregnancy in any given cycle. Compared to IVF, we can potentially give you up to a 60% probability of pregnancy with any given embryo, 60% with any given embryo. So if that's the case, gosh, an IUI just doesn't make a lot of sense. And especially with our costs for IVF here at CNY, after a few IUIs, you've already spent more money than you're going to be doing for an IVF that's going to give you an order of magnitude higher pregnancy rate. So for that reason, if you ask us, we tend to want to go first. We tend to talk about IVF as the better option. It's certainly the faster path to pregnancy and the more reliable path to pregnancy. But that's the reason why it's certainly more invasive. And yep, it is more expensive until you've done a few IUIs that haven't worked. And you say, crud, why didn't I just start with IVF? JMF, hello, and a long-time patient with CNY here in the Springs, getting back to it in November after a 2-year break and hoping for success. I tell you that there's a whole bunch of people out there tonight with fingers crossed for you, my friend. In fact, fingers crossed for everybody who's going through this journey. And I just love it that we can all be here for each other. And I'm looking forward to seeing your Christmas card with your baby on it. How about that? Balance Beauty Studio, can you please explain the Emma Alice Receptiva and ERA? Oh, yeah, that's a mouthful. So the ERA is what we talked about a little earlier. That's the endometrial receptivity assay. With the ERA, they often will run a test called the Emma and the Alice, which is a test that looks at the type of bacterial flora that's present inside the uterus and in the reproductive system, because we know what's supposed to be there and we know what's not supposed to be there, and sometimes those things that aren't can be there. In truth, I think it's kind of a relatively expensive way to do something that a simple endometrial biopsy will also tell you, because if there are some pathogens that are in the vagina that really have nothing, that the Emma and the Alice will test for, that don't have an awful lot to do with fertility. And there are also other ways to test that that can be covered by insurance. But since they don't have so much to do with fertility, I'm always a little hesitant to say that that's a great idea. A simple endometrial biopsy can look for the presence of plasma cells. Plasma cells are the immune cell that we see inside the uterus associated with chronic endometritis, which means a chronic inflammation in the endometrium or the lining of the uterus. That's often covered by insurance. So that's why I'm a little plus minus on the Emma and the Alice and the ERA, as we talked about. The data just isn't really supporting it for the general population. The Receptiva test, I think, is pretty good, anywhere from 93 to 97% accurate for diagnosing endometriosis non-invasively. And that's done through an endometrial biopsy. A little straw goes inside, sucks a little piece of tissue out at a specific time during your cycle, and it looks for the presence of a protein that's called BCL6. BCL6 is an inflammatory protein that's highly associated with endometriosis. And if that test is positive, then what it's telling us is that likely endometriosis is spoiling the lining of the uterus for an implantation. And what we know is that when we treat that endometriosis, or specifically treat that BCL6 with medication, usually for 60 days, that will increase the odds of a successful transfer by about 60%, actually by about 50%, up to about 60% in the very first cycle after that treatment was done. So some would say, well, don't even test. You don't have to do the test. Just take the medication if you want to. And that's an option too. Sometimes insurance won't cover the medication without a diagnosis. But the idea of doing the Receptiva test is because it can replace a laparoscopy. Now, that's controversial. There are plenty of doctors in my own company here who will say, nope, don't believe in that test. Everybody should be having a laparoscopy. And so, there is a difference of opinion there, but the Receptiva is a good test supported by a lot of evidence, and would like very much for people to avail themselves of that if needed. Let's see. Bailey Wand is 26 and just had a first egg retrieval. All 12 were poor quality. 3 of them fertilized. Should I transfer these embryos, or will it be a waste of money or time? Well, my opinion there is that I think you might be, if there's a chance of maybe doing another cycle to try to get better quality eggs, I would rather see you get better quality eggs first and bank your embryos, because you're never going to have eggs that are as good as the eggs that come from you at a younger age. So the younger we are, the better off we'll be. So let's say that of those 3 that fertilize, you now have 3 embryos. And let's say you do 1 transfer and it doesn't work. You say, damn. All right. So I'm going to come back next time. I'm going to transfer 2 embryos. So then we put those 2 embryos in you, and let's say one of them sticks and you're pregnant. Well, that's fantastic. Good. We got what we wanted. That's awesome. But it's going to probably realistically be another year and a half before you can go back and do another round of IVF. You're 26. You're going to be 28 next time. Is there a huge difference there? Well, not necessarily. There is a difference there. It's not the same as if you were 36 versus 38, because then the clock is really, going to be ticking on you. But I would say you are better off maybe thinking about another cycle before doing a transfer. Hopefully that helps you there. Hi to Rachel Chambers and to Heather. Heather Martell, how many failed IUIs before IVF should be considered? There's some data that shows us that 5 IUIs, that if you are not pregnant after 5 IUIs, then you are no more likely to get pregnant from IUI than you would be if you were doing home intercourse. So certainly I think 5 is plenty, but even in my mind, 5 IUIs is a lot of inseminations to have to do, because each one of them not only has a financial cost to it, but more importantly, there's an emotional cost to it. We're spending emotional capital every time we do something in the fertility world. So if you have to go through 5 months of each month timing everything and coming in and getting all the blood tests and having a speculum placed and preparing, providing a sperm sample and preparing that in the lab and having it placed and then waiting and waiting and waiting for your pregnancy test, that gets old. Right. So I spoke with a patient a couple of weeks ago who told me that her insurance will cover IVF, but it required 12 cycles of IUI. And I thought that was unconscionable because there is zero data to support 12 cycles of IUI. So in my book, after 3 IUIs, if it hasn't worked, it's maybe time to think about stepping up to something else. Let's see also here from Angelina. What is your take on the number of embryos to transfer? 1, 2, or 3? They are 3 days for someone who is 47 years young. Well, that's a good question. Angelina. So the guidelines say that you could actually transfer all 3 of those embryos and I would say that that's not an unreasonable choice. Why is that? Well, because the odds of all 3 of them sticking, a day 3 embryo and someone who's 47, the odds of them all sticking are very low. So certainly possible that one of them will stick. But I think that you should consider doing all 3 in that scenario because that's going to save you some money in the long run from having to come back and do transfer after transfer. And we will keep our fingers crossed there for you as well. Bonnie is asking, hi, Bonnie Rader. I have a consultation towards the end of September and have been on Mounjaro for weight loss. How long should we stop it before starting treatments? And you successfully you went from 245 pounds to 170. So yeah, that's fantastic. Mounjaro is a great drug, as is semaglutide or Wegovy. And it is all the rage now the other practice in our other, there are compounding pharmacies that are filling 4,000 to 6,000 scripts for semaglutide or Wegovy, the compounded Wegovy, a day. 4,000 to 6,000 a day. Can you imagine? So yeah, it's doing great things for people, but it is not approved for use in pregnancy, which is the point to which you allude. How soon should you stop it before you want to get pregnant? There's no good data on that. And to be honest with you, I would expect that at some point in the near future, we are going to see that it becomes approved in pregnancy. But until such a time, I would say 1 to 2 months is the current recommendation. It does stay in your body for a while. I have never seen anything that suggests that it actually causes harm to eggs or to a growing fetus, but there's just not enough data on that. And so nobody wants to tell you to use it if there's a chance that it could hurt something, you know what I mean? So 1 to 2 months, I think, is the answer there. Let's see here. Awkward Mara. I have my first FET on Friday in Buffalo. Nervous, not knowing what to expect. Well, fortunately, the FET process is really straightforward. I mean, it's pretty easy. You kind of come in. Important point. We want you to have a full bladder. Why is that? Because we're trying to maximize the amount of torture we can put upon you. No, not really. It's because as the bladder fills, it usually, for people whose uteruses sit forward, it pushes the uterus down. So it makes more of a straight shot for that little embryo transfer catheter to go through. So it's less of a cumbersome journey for your embryo if your bladder is full. Plus, we're going to have the ultrasound probe on your belly, sitting right on top of your bladder there. And to have a full bladder helps us to see everything that we need to see on the inside so that we can know that little transfer catheter is going into just the right spot inside the uterus, because it's not random. there is a target place inside the uterus when we do an embryo transfer. And so that's really it. Then we keep you lying there for about 5 minutes. After that, I usually tell folks that we want you to take it easy for the next 2 days. What does that mean? I'll tell you what it doesn't mean. It does not mean bed rest. Please don't be on bed rest. Bed rest actually makes things worse. But it just means nothing overly strenuous. And I always use the example of things like alligator wrestling and bungee jumping and BMX racing and helicopter skiing and that sort of thing. Hold off on that for 2 days and then you can resume, if you're riding in the rodeo, maybe wait a couple of days sure. Okay, what else we got going? Let's take a look at back to the Facebook side here. We've got a lot of Facebook questions today. When are they going to open in Sarasota? Well, I am told that we're getting closer every single day. They just got their one of their accreditations, so hats off to going through that process. It was a big to-do, and every time I see something about Sarasota, I learn that we really are one day closer each time. So hopefully sometime this fall. Ariel is asking, my beta at day 11 post-transfer was 140 and at day 15 it was 460. Why do other women's get into the 700 or 800 in those 3 days from the 100s? So what we're looking for there is a doubling of the number, at least a doubling of the number. 2/3 of normal pregnancies will have a pregnancy hormone level or a beta HCG that doubles in 48 hours. So yours was 140 at day 11. So by day 13, it should have been 280. So by day 15, it should have been about 280 and 280, so about 600, or a little bit less than 600, 560 or so. Yours was 460, so it didn't quite double there by that second 48 hours. So usually I would then want to see, well, what's it still doing? Because some normal pregnancies, the number just doesn't double. It's still going up, so that's a good thing. But the thing we're always worried about in a number that's not doubling is to make sure that that pregnancy is inside the uterus, that it is not a tubal pregnancy or an ectopic pregnancy. So that's why we follow those levels. And Ariel, I think you probably are going to be due for another blood test. Let's see what we got here. I think that's Michaela Lex. You know what? Micah, Michaela, you know who you are. My husband is 28 and I'm 25 and we are male factor only. It was recommended to do mini dosage meds, but another fertility clinic suggested standard dosage for best results. I would kind of disagree with that, my friend, because, and I'll tell you why. If you're 25, so the way we decide on what the dose of medication is that we're going to use for you for IVF is based on, number one, based on age, and number two, based on your AMH level. So I'm assuming that your AMH or your ovarian reserve is normal for a 25-year-old. If that's the case, the mini dose is really the standard dose. That's the normal dose for you at 25. If you used what I might think of as a standard dose, like getting to be the 300 of your FSH or your follistim, that's going to be way too much for you, and you will end up badly hyperstimulated. So 200 is a completely appropriate FSH dose for you, just based on your age. And in our mini dose protocols at CNY, 200 is the dose for mini dose. So it's not that we're giving you something less than what you might expect, because the standard dose for you is the mini dose by our definition. I hope that makes sense. Well, what else we got going on here? Hi to Brandis, who joined us. Do we do transfers on Saturdays in Colorado? The answer is yes. All of our locations do transfers 6 days a week. The labs and the clinic are closed on Sundays. But even I think actually we're closed on Christmas morning, and I think we're closed on New Year's morning. But other than that, I believe we're open every single day the rest of the year, but not on Sundays. Um, Maru Tian. How can I schedule a consultation with you, Dr. Fink? I was diagnosed with diminishing ovarian reserve. Any of our wonderful providers can help you with that issue. And how do you do that? You can request an appointment online through the cnyfertility.com website, or pick up the phone and call us at the call center and ask if you have a particular provider that you would like to speak with. Either get on the schedule with that or get on the cancellation list, and let's see what we can do for you, my friend. Hello, Skylar. My wife recently had her retrieval. Is it okay that she goes straight into an FET, or does she need to wait for her second cycle to balance her hormones? Should she get a hysteroscopy before the FET? Well, that is a good question, Skylar. So, first thing I would say is that if she has not had her uterine cavity evaluated, I would strongly encourage you not to think about doing an embryo transfer until that's taken care of. Why not? You don't want to waste a precious, beautiful, perfect little embryo unless you know that that uterine environment is just as precious and beautiful. You know what I mean? Why take the risk? So if she has had a saline sonogram, or if she's had a hysteroscopy within the year, then that's considered adequate cavity evaluation. If she has never done that, I'd strongly recommend she do one of those things before going into the FET. However, so typically you do a retrieval, and usually about 10 days or so later, you get a period. Once that period starts, you go right into your FET. There is no data that shows us that there's any either a downside or an upside to doing that. We know that doing recurrent, repetitive, or stacked retrievals is helpful for egg quality and egg quantity as well. But as far as transfers go, you can do whatever is the easiest thing on you. Sometimes, emotionally speaking, you may just need a break, or you you want to just kind of go, whichever is the best choice for you. There is no medically wrong choice in that scenario. But hysteroscopy or saline sonogram, if she hasn't done it, please do it. Is endometriosis hereditary? There has been some evidence to show family relationships with endometriosis. So I would say the answer is probably yes. The mechanism of how endometriosis happens is not completely understood. There are different theories about that, but certainly we do see it run in families. So yeah, for sure. Me Gang 30, I've been a poor responder, causing 2 different IVF cycles to be canceled. Any ideas to how to increase my receptivity so that I can try? Yes, the first thing is there is a specific list of supplements for people with a diminished ovarian reserve or who are poor responders. That would be number 1. Metformin increases your response. Omnitrope, human growth hormone, improves the potential quality of your eggs. So better eggs mean better able to retrieve them. I would think about those 3 things. There are some specific protocols we have also for poor responders. So me gang, I would recommend talk to one of us and let's see what we can do to find out what's going to work the best. Looks like we've got just a couple of minutes left here in Fertility with Fink and Friends on our Tuesday afternoon. I hope you're having a good a time as I am. Let's see if we can get a few more questions in here. Lindsay, hello, Lindsay. Oh, where did your question go? Oh, Lindsay Hogan, I just saw you there, and I think you disappeared. Oh, that was the strangest thing I've ever seen. Oh, there we go. Got it. Is an HSG or a saline sonograph required if we're male factor and we're planning on IVF anyway? I do not think an HSG is a necessity. There are many people who feel like, oh, you have to do an HSG because that's going to show that your tubes are not full of fluid. But even the most important textbook we use in reproductive endocrinology, which is by a guy named Spearoff, says that the HSG is not the test of choice to determine if there is fluid in the tube. So if I know that you're going right to IVF, I say no HSG is necessary. But like I just mentioned about the saline sonogram, I feel very strongly the saline sonogram you want to do because we're making embryos. We want to know that that uterine cavity is just as perfect as the embryo. It's quick, easy to do. And in some of our locations, you can even do it at the time of your egg retrieval. So something to think about there. Can you, let's see what we got here. I can't tell what you're asking me there on that one. Nancy Fitz is saying, what does it mean when the report says endometrial borders are not well defined and uterine contour appears abnormal? I've had 4 failed transfers. The endometrial borders, I think that may be talking, that's not a term that we usually use, but I think that may be talking about adenomyosis, and that is something that we can treat. So I think that's worth talking to us about. But gosh, it looks like we are going to be out of time here today. Thanks so much for being with me on this Tuesday afternoon. We'll be back next week as well. Remember, fertility is only a piece of your journey. It is but a chapter in this novel. It is not the title of your book. And we are here to help you rewrite this chapter. God bless you all. Thanks for being here. We'll see you next week. Good night.